We need the nourishment of food to maintain life. Sometimes that very sustenance can fight our body's defenses. Adverse food reactions tonight, on call with the Prairie Doc, celebrating our 20th season. Hello, I'm Dr. Jennifer May with the Rapid City Medical Center. Thank you for joining us as we celebrate our 20th season of truthful, tested, and timely medical information. It is said we are what we eat, but sometimes there is a conflict between our bodies and our food. To discuss those problems tonight, here in the South Dakota Public Broadcasting Black Hills studio in Rapid City, is Dr. Halie Anderson, a pediatrician and allergist at the Rapid City Medical Center and a hospital medical staff at Monument Health, and Dr. Kimberly Hushagen, a pediatrician with Black Hills Pediatrics, who is also on staff at Monument Health. Welcome.
Thanks.
So please, Dr. Anderson, I'll start with you. Why don't you tell me a little bit about yourself and how you came to Rapid City?
Sounds good, thank you. Thanks for having me. Yes, my name is Dr. Halie Anderson. I hail originally from South Dakota. I grew up in Spearfish. And I did medical school at the University of South Dakota and first did a residency in pediatrics. So as you mentioned, I am a board certified pediatrician at the University of Wisconsin-Madison. I did a year of hospitalist work as a pediatrician, but decided to do some extra specialty training in the area of allergy and immunology. And so it is a unique specialty in that although I'm a pediatrician, in my specialty training I actually see both children and adults, and did a fellowship in that also at the University of Wisconsin. Given that I have family here and I'm from this area and we love it, we came back to Rapid City about 4 years ago now. So that is kind of my background.
Wonderful, and you've been a great addition to our community.
Thank you.
And Dr. Hushagen, you're a little bit newer to our town, so tell us a little bit about how you came to Rapid City and your background.
So my husband and I moved here about a year ago. I'm originally from a super small town in North Dakota called Montpelier, which you've probably never heard of unless you're from the area. And then my husband's from Bismarck, North Dakota. We met at the University of North Dakota where we both did medical school, and then we did our residency training at Penn State Hershey in Hershey, Pennsylvania. So as you said, I'm a general pediatrician at Black Hills Pediatrics. My husband's an internal medicine physician with Rapid City Medical Center. We both wanted to come back to the Midwest. We loved the area and we're happy to be here.
Wonderful, well, welcome. So I thought I'd start out with just sort of the basic question. I'm first gonna direct it to Dr. Anderson. So what is allergy, or what is food allergy? Tell us a little bit about that.
Yeah, I think the best way to explain or define food allergy is basically when the immune system basically recognizes a protein that should be harmless to us as being dangerous to us. And we don't know exactly why that happens, but it's very common with foods where certain food proteins will trigger the immune system to make an antibody or a protein that again says, you know, this is bad for me. And when that happens, or when you're exposed to that food protein, your body goes into a dangerous reaction. And it can be, it can be mild depending on how much you eat, but it can be severe and in rare cases lead to death. And that's one type of food, or that's how I define food allergy, is what we consider this IgE, which is an immune reaction mediated food reaction or food allergy.
So Dr. Hushagen, what about food sensitivities or intolerances? You must see that a lot as a pediatrician.
Yeah, so there's definitely a wide range of sensitivities or intolerances we can see, ranging from, a gluten intolerance versus a celiac disease versus a lactose intolerance or milk protein intolerance. So there's a wide variety that we can see with different foods that infants can ingest.
And so what are the common ways people present? How do you as a pediatrician differentiate a food intolerance versus an allergy? How do people come and report symptoms to you?
So a food allergy is definitely a much more severe reaction, and typically as you continue to get exposed, your reaction gets more and more severe if you have a true allergy to that food, whereas an intolerance could be, some mild vomiting, a rash, a weird sensation in your mouth, like a tingling sensation if we talk about oral food allergy syndrome, or, some diarrhea. So there's definitely it's a less severe reaction than a true anaphylactic reaction.
Yeah, and I would just kind of piggyback on that. A lot of it really comes down to the history. So as a provider, when you're seeing, a parent bring in their child with some sort of food reaction, we're really trying to get kind of some of the specifics of the timing. What did they eat? How much did they eat? When did the reaction happen? We really like pictures, I do anyway. So if, parents take pictures of the rash that the child developed and when that, the timing of the rash development in relation to when they ingested the food. Have they had that food before? In what forms have they eaten that food? That sort of thing. So we're really asking a lot of specific questions, getting at the history, which as providers, knowing the pathophysiology of these different reactions helps us to decide, does this seem more like a true food allergy, or could this be in the realm of a food intolerance, which is a different pathway?
And what about, some people say it's something in the food, like a dye or a chemical. How do you answer that question? Is it not bread, it's, I don't know, something else? Is there some other way you differentiate other reactions?
I would say that, again, it a lot of times comes back to the history. And then I as an allergist, we have the ability to do allergy food testing. And so some things we can test for and some things we cannot test for. And so, again, a lot of this is a conversation about what our limitations of food allergy testing are, which is that it looks at one specific process. I talk a lot about how there's lots of ways in which foods can interact with our body in a negative way. But there's maybe only one narrow pathway that we have good, reliable testing for, which is that IgE-mediated food allergy. And so if a reaction sounds like it falls out of that pathway based on the history of the reactions, we don't really have good testing for it. So it comes down to, elimination, the parents doing an elimination, maybe journaling about the symptoms that they see to kind of corroborate that. So I don't know about you, but I hear about parents being concerned about red dye very frequently. Mm-hmm. Mostly behavioral, or my child seems like they get very angry when they have foods that have red dye in them, and there's probably or maybe something to that, but at the end of the day, the testing is not going to pick that up. And so some of it is like, if you recognize that as a pattern with your child, I respect that, and I think that maybe avoiding those foods as much as possible is great. It's unlikely to cause a life-threatening, dangerous reaction to your child.
So it sounds like it's important to figure out the difference between sensitivity and the allergy is avoidance. Obviously for both, you're going to avoid things that bother you, but the degree of the reaction kind of helps differentiate maybe the underlying mechanism a little bit.
Certainly, and from a safety standpoint, do I need to be fearful of my child's life if they're exposed to this incidentally in the care of someone else or something like that?
And we know a lot of this comes up in childhood. Do people outgrow these types of reactions?
So a lot of times they do. And so I typically am kind of your first line. I see it often in my clinic, and that's where I do refer to Dr. Anderson for the kids that I'm concerned do have a true allergy, because a lot of times they can do testing or serial testing, and a lot of kids do outgrow allergies.
And what about adults? Certainly I'm a rheumatologist and I get asked about diet all the time, and people, are really focused on diet in terms of our immune system and inflammation. You hear about that a lot. It seems like, why do we acquire some of these? Do you get allergy, I guess, as an adult, or is it only sensitivities?
Yeah, I see a lot of adults who, are referred or self-refer for concern about food allergy. And again, most of the time, true food allergy or this IgE-mediated food allergy is more of a childhood problem. Now, there are some exceptions. Shellfish allergy is one that sometimes comes on a little bit later in life or early adulthood. Celiac disease, which is a problem with gluten, is not, I guess you can define it as an allergy, but it's a little bit of a different testing process. That's a little bit more common as we're exposed to gluten more and more as life goes on. But beyond that, the true food allergy or the IgE-mediated testing that we can do in adults is pretty uncommon. So it tends to be more food sensitivities or intolerances, which is just more common as we get older. And I'm not sure what that is, if it's something about our guts, immune health, or ability to tolerate different food proteins. We don't really understand that very well, but we definitely, I would say that's very common for people to feel like they don't tolerate food as well as when they were younger.
And what about people who because again, gluten, it seems like everyone has a gluten sensitivity, I guess is what I would say. So how do you do, we do testing for celiac, and if that's negative, how do you define gluten sensitivity versus allergy, I guess? And then is that same true, like it's more starts in kids, or is that an adult acquired phenomenon? I'll start with, I guess, Doctor, do you feel like it's more common in kids?
So I typically feel, kind of like Dr. Anderson said, is we see like more intolerances as you get older, whereas, and celiac disease also we typically don't see in like the young childhood. You could see it as early as when foods are introduced, and we do have blood tests that we can do to tell like, is this truly celiac or not, or we might have to refer to a gastroenterologist for like a scope to do testing of the gut itself. But then if that's negative, like the testing itself is negative, but we still see that you can't tolerate gluten very well, or whether it be red dye or any other food, then it's all about knowing your triggers, keeping a good journal to see like, oh, if I eat this, then I feel bad. Then we don't want you to eat something that makes you feel bad. It might not be a true allergy, but if we know it causes a reaction in you, then we just recommend avoidance.
Yeah, I always kind of tell people that their body is better than any sort of testing that we have at our disclosure. So sure, we have blood testing and skin testing and that sort of thing, but if their body is repeatedly telling them, this makes me feel bad, it seems like it's too much common sense, but listen to that. Your body's telling you that this doesn't make you feel good, and I respect that kind of a thing.
Wonderful. So if somebody has a gluten sensitivity self-diagnosed, could it be other things? I mean, is it not really, I'm assuming there's lots of products in bread or wheat, lots of other proteins that might be the problem. It's not necessarily gluten, it's just avoiding bread that helps, or how to?
Could be. I think this is where it gets tricky, right? So gluten is in some ways has become a fad.
Right.
That it's kind of trendy, I guess, if you will, to have a gluten intolerance or do a gluten-free diet. But they're truly people who have celiac disease where eating gluten, causes an immune reaction in their gut that can cause a lot of different problems. And again, there's definitely people who when they consume gluten don't feel very well. They may feel bloated or get low energy or have brain fog and that sort of thing. Could it be that it's a diet that's high in grains or high in processing or other things that are contributing? Very, very well, maybe. But again, it kind of comes down to, and I think this is the hard part for people, understandably, is life is busy. A lot of times we're eating on the go. Mm-hmm. It's very difficult to constantly be label reading and to truly do a food diary and do it well is really time consuming. And so I think naturally a lot of people are looking for, testing or something to help ease that process or make it more simplified. And unfortunately, our testing is limited in that way, and that it's not always as helpful as we would love it to be.
So when do you utilize, we talked about gut and gut symptoms, when do you have to utilize maybe the support of a gastroenterologist or a referral, like beyond allergy, immunology? What other specialties do you guys utilize to help you pin these things down?
I think those are probably our main referral sources. As a general pediatrician, I kind of serve as first line. I can do a basic workup. The history that the parents provide is our biggest clue as to what's going on, and then we can see, does it seem like it's more like an allergy? Does it seem like it's something in the gut where we need a gastroenterologist to be involved? Those are my big referral sources that I use.
Yeah, I think, and we're looking for, there's other things, obviously, inflammatory bowel disease and things like that. And in children, a lot of times poor growth is a trigger for us to be thinking about, is there something else going on in the gut? Are they not absorbing their nutrients the way that we would want them to? In adults, if, stooling patterns and mucus in stools and blood in stools and weight loss and things like that, there are some danger signals, I guess, that you can sometimes elicit from someone's experience that we would refer to gastroenterology. And some people are just really uncomfortable and miserable, and they feel like it's related to foods. If we haven't been able to help them from the allergy perspective, sometimes I will refer to our GI colleagues, and just for another perspective, from maybe get some help from nutrition, that sort of thing, to just kind of say, we're still struggling, this person's quality of life is poor. What do you have to add to this story to kind of help them feel better?
What about probiotics? Are they worth recommending?
So I think probiotics are becoming more and more studied as we have, this focus on your gut microbiome and overall gut health and how that can have long-term impacts in kids. There are some studies that it helps in like colic symptoms. So I typically want you to speak with your doctor first to make sure we don't have some sort of immune deficiency, we're not a high-risk infant. And then as long as you talk to your pediatrician first, it's sometimes worth a try to see, does that help balance the good bacteria versus the bad bacteria? And I have seen it in my practice where parents notice a significant difference after we start probiotics.
Okay. Do you recommend probiotics to your patients, or is that
Yeah,
still
no.
unknown?
Well,
or?
yeah, I think it's the gut microbiome is very, very difficult to study because there's just a vast amount of good and bad bacteria in our gut. It's like its own organ system is the gut microbiome. So I rarely think that probiotics are dangerous, and I certainly think that they may help people, particularly if they're needing to go on antibiotics frequently and that sort of thing. I think the struggle is whether or not knowing those probiotics are actually taking hold. I think that's a big question. Is it just, a breeze through the window where you're taking something and hoping that it takes hold in your gut versus does it actually integrate itself into your gut microbiome? And I think that's a question that we don't know for sure, but in general, my approach is that it's worth trying, and if it makes you feel better, I think it's unlikely to be harmful.
So it's, like you say, it's not going to hurt. It may not help, but it's generally not harmful. And there's not, from my understanding, a particular, there's just so many choices that it can be a little overwhelming to know which bacteria, how many colonies, and you get the refrigerated or the ones off the shelf, and that's still a little unclear. Is it not? Yeah, there's all these different strains of lactobacillus and that sort of thing, and so which one is it that is actually helping with colic versus maybe doing nothing? And again, it's very difficult to study this because there's just thousands of different bacteria, and it changes, from day to day and week to week. Someone's microbiome might be different, and so challenging to know what is what with a microbiome. So time will tell a little bit.
I think
in that
so.
area.
This is a buzzword.
Okay. One of the common food allergies is peanuts. We've heard of the tragic cases when someone has died from the accidental eating of peanuts. There's a new treatment to reduce the reaction when a person who has a peanut allergy is exposed.
A new treatment is available for children ages 4 to 17 who suffer from peanut allergy.
Palforzia is a new product for peanut anaphylaxis. Anaphylaxis means that you've got at least two systems involved with the reaction. Normally there's hives, usually there's swollen throat, can't breathe, maybe vomiting, diarrhea, low blood pressure, pass out, and potentially death. So if you have anaphylaxis, then you're a candidate for the Palforzia if you're a child. So it's between the ages of 4 and 17, a person needs to start it. And it's going to be every day for the rest of your life to keep you less allergic to it. So it's a kind of a safety net. It's not a cure, and it's important for people to realize that.
Palforzia is a low dose of peanut protein. The hope is that by taking it daily, it will decrease the chance of a severe allergic reaction if the patient accidentally ate something with peanuts.
What's really neat is that if you are out and about, you eat some peanut just by a cross-contamination, just a small amount, say less than a peanut, most people just have a mild reaction, not a full-blown horrible anaphylaxis with this. So it's a neat new treatment. Looks like it runs about $12,000 a year, and most all insurances are covering this within your policies, deductible and such. So it's the only treatment that's out there to do anything.
Once this treatment is started, the patient must continue to avoid peanuts, and Palforzia must be continued long term, so it's not for everyone. According to Dr. Bubak, at least 18% of people outgrow peanut allergies in their lifetime.
So far, we have a total of 1 that's wanted to do it. We talked to lots of people. One of the issues is this is not without side effects, but anaphylaxis from peanuts not without side effects too. So if you're just a regular person trying to avoid your peanut, about 3% of patients a year are going to anaphylax, is what's the normal rate. With this drug, 15% of people have reactions. That said, it's going to happen at your house. You're going to have your EpiPen there, and generally they're milder. And then when your child has a reaction from an accident at their friend's house and has forgotten their EpiPen, you hope that things are mild and things go better because of the treatment. But it's still a big leap for parents and kids. I mean, they've been deathly afraid of this peanut stuff, and then now to take that every day is a whole new mindset. And I think it's going to take a little while for people to fully understand and appreciate where it fits in.
So what has been your experience with patients who have peanut allergies? Dr. Hushagen?
So one of the things that I recommend is, so typically foods start somewhere around 4 to 6 months of age, depending on your kid's developmental abilities. So I am a proponent of early introduction of allergens, because there has been some studies that introducing early decreases your risk of allergies later in life. So typically how I recommend starting it so we can see if there's a reaction is, after a couple solids have been introduced and we've tolerated those well, I recommend starting either peanut or egg as your major allergens. Only doing that food, start with a small amount in the morning so you can watch them when they're at home, gradually increase throughout the week and see, are there any reactions we can notice. So typically the first reaction you have is mild, and it usually takes, multiple exposures to the food before your body decides whether it likes it or doesn't like it. And so we might see just a mild rash, like a few hives here and there. If you keep getting exposed to the food and you have, a severe symptom from one body system, is how we kind of describe anaphylaxis, one symptom that's severe from one body system or more than 2 symptoms from different body symptoms that are involved, then I get concerned that there's a true anaphylaxis or allergy to it. So might be a rash, and we're starting to have difficulties breathing. Then I get concerned, and that's where I either do testing in my office or I refer to our allergist for further testing.
So how common, and I don't know how easy this is to answer, but like what percentage of little babies, as you introduce food, have reactions? Is it? I mean, I know we say it's pretty common, but at the same time, I would think it'd be not that common.
I'll probably defer.
Does
I don't
that
know the
make
exact
sense?
numbers of it.
Like,
Yeah.
is it 10% of kids?
About,
Okay.
yeah. So I think that on average it's about 1 in every 13 children in a school age classroom will have a peanut allergy. So if the average classroom has about 25 kids, you approximately have 2 children in each classroom with a peanut allergy. Now again, that's school age, so I don't have exact statistics for infant populations, and that's probably changing and a little hard to study. But yeah, it's really common, and we think about when we were young.
Yeah.
I mean, you didn't even think about it. It wasn't. I literally cannot think of a school classmate that had a peanut allergy.
Right.
And now it's very common.
And again, we're just not really sure why that is.
It's probably multifactorial, like most things in life. Maybe there's some component of us being too clean. Mm-hmm. We're using hand sanitizers, and we're very, in general, focused on being a clean, washing with soap and getting the dirt off and that sort of thing. Interestingly, in this country, the lowest allergy happens in people who are raised or born on farms, and specifically the non-modernized farming. So Amish communities and things like that have very, very low incidence of food or just general allergies. So there's probably something about what we call this hygiene hypothesis, that we're a little bit too clean. It's probably related to maybe some, dietary exposures and the processing of our food.
Right.
It's probably related to our gut microbiome and maybe overuse of antibiotics in both treating things and maybe even in our food sources. And it also is probably recognition. We're looking for it more, testing for it more. So it's probably a combination of things.
Do you have experience with the Palforza, like Dr. Bubak was talking about?
Yeah, so my experience is similar to Dr. Bubak in that I haven't found a lot of families ready to jump on board with this treatment plan. I do think that oral immunotherapy to foods is the future of food allergy management, and Palforzia is the only FDA-approved product that we have at this time, but there are Lots of things in study. I would say there are lots of allergists doing non-FDA approved immunotherapy to foods as well. And again, immunotherapy is this idea that we're exposing the body to what it's allergic to induce a state of tolerance so that there's not the severe reactions. And Dr. Hushagen mentioned the early introduction of allergens is kind of one approach to kind of prevent the development of food allergies. So in some ways you could think about that as being an oral immunotherapy, but you're starting it before the problem happens. Because we know even in children who may be at high risk for peanut allergy, like for example, their skin test is positive, but if we can get peanut into their diet in the form of peanut butter or something like that safely and on a regular basis, by the age of 5, they're much less likely to have a lifelong peanut allergy. So back to the palforzia, it's a pretty time-intensive process for families. They have to come into an allergy clinic every 2 weeks during an updosing process. So, they're coming in to get the exposure to the powdered peanut. And every 2 weeks they get a slightly higher amount. And then at home every day they're getting exposed to that. As Dr. Bubak mentioned in his segment, there's a relatively high risk of reactions. So something like 12 to 15% of children needed to be treated with epinephrine in the studies. So again, it's pretty high and kind of a tough sell for families where they say, I have an 8-year-old, we haven't had to use his EpiPen for his whole life. And you're telling me now that there's a 12 to 15% chance that because we're actively doing something, we might have to use the epinephrine. And so that I think is difficult sometimes for families to decide if that's the best option for them. And then the other part of it is we're not curing the peanut allergy. It's not going away. This child is never going to be a child who can eat a peanut butter sandwich one day and not think about it and 3 days later eat a peanut butter cookie. The palforzia or the peanut protein becomes their medicine. And again, it's to protect them from severe accidental exposures. And at the top dose, they're getting about the equivalent of 1 peanut kernel. So you're protecting them to about 1 to 3 peanuts probably. So it's really exciting. I think it's exciting that we can have something that we can actively do. And again, I think the future of this is only going to get better and better. But I also, like Dr. Bubak mentioned, there's a lot of other considerations logistically for families that has made it, people are somewhat reluctant, I think, to jump on board.
I think sometimes it's become the chronicity of, sometimes we have these therapies in rheumatology. Once you start them, we want you to continue them. And for some people, that's just too much to think, I have to do this forever. And that's just not.
And I think practically speaking, a lot of allergists would use the palforzia to kind of get them up to a top dose and maybe do that for 1 to 2 years. And if they're doing good, challenge them to actual peanut product. Okay, we're going to transfer now to 1 to 3 peanut M&Ms a day, which is a little bit more practical from a cost standpoint and that sort of thing. Now, interestingly, though, a lot of these children don't like peanut. They don't like how it tastes. Their body has naturally developed this aversion. And so that's another thing that can be a challenge for families is they have to find ways to mask the peanut flavor because, again, kids don't like it. And so, there are interesting other logistics that come into play.
What about with pregnancy? Is there things the pregnant mom can do to reduce their chance that their baby, I guess you don't see them till after they're born, but do you have any insight on that as a pediatrician?
Yeah, and it also applies to breastfeeding too. So I just encourage, moms, whether they are pregnant or breastfeeding, to eat a wide variety of foods because there are, some of those proteins that, are in their body floating around or go through their breast milk that their child's exposed to and could hopefully decrease the risk of having reactions later on. One of the most common ones is milk and soy protein intolerance that we can see in kids, and hopefully exposure frequently early can decrease that risk.
And what are some, we've been talking about peanut, but obviously we've talked a little bit about gluten. What are some of the other common food sensitivity reactions that you interact with patients?
And so the most common allergens, and I like to give my patients a list before they start allergens so they know which ones to maybe do individually rather than exposing multiple things all at once, is obviously peanuts, a huge risk, tree nuts, your shellfish, both your fish and your other seafoods, your gluten or wheat products, soy and dairy products are and egg are the top ones that I see that people have difficulties with or potential reactions to.
Do you, as an allergist, is it mainly peanut and you know, which ones tend to be the most cause the anaphylaxis, or can any one of those allergens equally cause the anaphylactic type challenges?
Peanut and tree nut tend to be the most severe reactions because it tends to require the least amount of protein exposure. Milk and egg are by far and away much more common, but interestingly, milk and egg are less allergenic in extensively heated forms, so it's very, very common for children to be able to tolerate baked milk or baked egg, you know, so they can eat a muffin that's been baked with egg in it, or, you know, they can have pancake batter that has egg or milk in it. And do okay, but if they eat cottage cheese or they eat scrambled eggs, they have a reaction. And so again, there's a little bit of nuance there with the milk and the egg in terms of what forms that they can tolerate it in. The good news about milk and egg allergy is that they're very commonly outgrown. And if they're tolerating it in baked form, that's a very good prognostic sign that they're likely to outgrow it by the time they get to school age. But I would say in terms of severity, the peanut and the tree nut tend to be the ones that cause the more severe reactions.
More likely to require the EpiPen and have that in your possession.
Yep.
Interesting. So in terms of egg, for example, or milk and soy, you mentioned soy allergy. So how do you help a family, like, oh, you know, I'm giving my kid this formula and now they're vomiting all the time? Is that, I mean, that happens a lot with babies, right? As a mom who's fed babies, that's not uncommon. So how do you differentiate those challenges?
Yep, and a lot of it goes back again to the history parts of things. And so if we see like, there's different, you know, there's the, as we've been talking about this entire show, the intolerance versus the true like allergy, anaphylaxis type of thing. So milk and soy commonly cause like an intolerance, like milk soy protein intolerance, which can cause like poor growth, very fussy, colicky babies that persist, some blood in the stools. If that's happening, then we typically do a trial either of an elimination diet if mom is breastfeeding, or there's different types of formulas that have either low amounts or none of those type of proteins in them, and see how baby does. If it's truly like where every time we get this reaction where we're like profusely vomiting or having diarrhea and we're poor growth, those might be more of a severe reaction where we do need to get allergy immunology involved to see like whether this is a true IgE-mediated anaphylactic allergy that we need completely avoid, or whether we can introduce it back in their diet.
Wonderful, great information. Another common type of condition, especially among kids, as we just mentioned, is milk allergy. We spoke with an allergist about it.
Sanford Health allergist Nikki Patel says milk allergy is quite prevalent in younger kids.
Milk allergy is one of the ones that tends to be more likely to be outgrown as children get older.
However, she says there are some people that may have milk allergy into adulthood. The symptoms are wide-ranging.
For some children, it can flare up their eczema to be worse. For some people, milk allergy can cause symptoms such as hives, facial swelling, shortness of breath. For some people, it can induce something called FPIES, which is food protein-induced enterocolitis. And so that can cause vomiting, diarrhea, like feeling very like lethargic and very pale and having decreased muscle tone. So milk allergy can kind of encompass lots of different types of symptoms.
Patel says there are two types of tests to check for milk allergy.
One is the skin test, and sometimes people can't do skin testing because they can't be off of certain medications that affect the skin test, so then we have the option to do blood testing. And oftentimes, even if we are able to do skin testing on patients, we do the blood testing just to confirm the results.
Patel says the process of testing for allergies has become a lot more painless the last 20 or 30 years.
And so it's a pretty simple procedure. We just have people typically lay on their stomach because we apply the test to the back, and we just press these plastic tip devices on the back, and we leave the liquid on the back for about 15 minutes. And then we have our answer, you know, typically at that same appointment on the first day. And then the blood testing is just a simple blood draw.
Patel says milk can sometimes be tolerated better for people when it is in baked goods, rather than a glass of milk or ice cream. Depending on severity of the reaction, you could be prescribed an EpiPen.
If you are allergic to all forms of milk, that would include very detailed label reading in terms of foods that you order, making sure that a waiter or server at a restaurant you go to is aware of the milk allergy.
common is milk allergy compared to environmental allergy? Dr. Anderson?
In early life, it's pretty common. They're different beasts, I guess. So food allergy is more common in the infant and childhood population. Environmental allergy, specifically seasonal things, is something that tends to develop more between the ages of 3 to 7 and then later on into adulthood. So I would say in the early childhood period, milk allergy is more common than environmental allergy perhaps, but that certainly flip-flops as children age and into adulthood, obviously.
Okay, and how, we get these questions a lot. I was at the pharmacy recently waiting to pick up something, and I see all these boxes on the wall of different home kits that you can take home and find out what's bothering you. How do you feel about home testing kits for allergy as opposed to the type of allergy testing you do?
Do you want me to take this one? Go ahead. So I have to be honest, so there's many of these kind of commercially advertised food sensitivity tests that you can get at the pharmacy. You hear commercials about them. I don't put a ton of grain of salt into these tests because the science doesn't make a lot of sense to me. We've kind of in this discussion, I've been talking about true food allergy, which is the IgE-mediated immune reactions to foods. What these food sensitivity tests employ is something called IgG, which is a different antibody. And generally speaking, this is an antibody that's a marker of exposure. Now, there are flavors of this in rheumatology. Obviously,
Sure.
IgG can be a little bit different, but in general, when we're thinking about immune system memory, if our body's been exposed to a particular virus or bacteria or vaccine, we make IgG to that particular trigger as a marker of memory and exposure. And so when you translate that into foods, a high IgG level to milk may not be a danger signal. It may just be that that's something that you frequently ingest in your diet. And so that's where my beef is, I guess, with these food sensitivity tests, is that I think it's difficult to correlate a high sensitivity that they elicit to what a patient's actual experience is. And a lot of people find them very overwhelming. They'll say, well, my food sensitivity test said I'm sensitive to 50 foods. What do I do with this? Like, is this accurate? And I agree that it's very hard for me to give them clear guidance because, again, the science doesn't make a lot of sense, and I don't think they correlate strongly.
Is it going to change what you would normally do anyway? I mean, you're going to have to still go through your same diagnostic process that you would have anyway, despite this home kit information.
At the end of the day, you're going to still have to do an elimination to see if it makes you feel better. And so I guess when people have already done this, my advice to them is say, maybe pick 1 or 2 of the things that are higher on the list, try a stepwise elimination where you take it out of your diet for 2 to 3 weeks and see if you feel better. If you feel better, great, try to limit that food. If it makes no difference, put that food back into your diet and go on to the next food and maybe use it as a guide. But putting a lot of hope in these tests, I think, unfortunately, is...
We're certainly not encouraging people go out and do this before you go see your allergist. There's no necessarily any value there. It's more listen to your body and start working there and from that perspective. So what about, I shouldn't say we all, but a lot of people have some dairy sensitivity as they get older. Maybe I'm self-diagnosed lactose intolerance or whatnot. How is that? Is that different from allergy, or is that just on the spectrum of allergy or sensitivity, or what would you say?
So typically what we see with like a dairy intolerance is more that we have an enzyme, and luckily our culture is one where we typically have more of this enzyme than other cultures, so we get the joy of, enjoying ice cream or milk or whatever it is. And as you get older, I feel like that enzyme is not working as well and you become more intolerant of dairy. There is the very rare child who's born where they actually can't tolerate lactose at all, but it's more of the kind of intolerance rather than the true allergy to it.
Yeah, I think how I explain it to people is that with milk products, an allergy is to the proteins in cow's milk, so the casein and the whey, whereas a lactose intolerance, lactose is actually a sugar in cow's milk, and some people just don't have the right enzyme in their gut to break down that sugar. And as we get older, that enzyme tends to work less well, and as Dr. Hushagen mentioned, certain ethnic populations don't have it at all. So, for example, I think in the Filipino population, 95% of people are lactose intolerant. So there is definitely a difference. It's a real thing.
Right.
But a milk allergy skin test that I do in my clinic is going to be negative even if someone has rip-roaring lactose intolerance, because it's a different process.
Interesting. So how do you feel about, or how do you approach some of the skin reactions, particularly in kids, but also to some degree in adults, certainly, that people, as we mentioned, it's your gut. We talked about the bloating and the diarrhea that some people experience, obviously the anaphylaxis, the respiratory, the shortness of breath. But what about some of these skin reactions, the hives, the itching? Some of that can be really challenging.
And so typically what I recommend parents have on hand when they're first introducing food is Zyrtec is my kind of go-to over-the-counter allergy medication that they can have at home, because it's a more long-acting allergy medication, and it typically doesn't have the side effects like Benadryl, where your kid could either get very hyper or the opposite, super sleepy. So I just typically say have Zyrtec on hand that you can use if you start to have a mild reaction.
Yeah, and certainly there are many children who have really bad skin conditions like eczema or atopic dermatitis. And this is definitely, if your child is experiencing that, it's really worthwhile having a conversation with your pediatrician, potentially considering referral to dermatology or allergy, because certainly allergens can play a role in something like eczema. Really important for young babies to just be well moisturized. So, kind of using good moisturizers, not like the lotions that you can pump out, but the ones that you can scoop out with your hand, or kind of the greasier ointments like Aquaphor,
looking
Vaseline, those sorts of things, because we know that good skin barriers actually decreases the risk of allergen production, allergy development in children. So that can be really helpful.
Even just in general, as another, along with introducing foods early, just keeping that skin healthy reduces that exposure to things, because that's your best barrier is your skin.
Yes, we think some kids develop food allergy, they actually get sensitized through their skin, which is really a fascinating whole other probably topic. Keeping that skin barrier really healthy and moisturized, which is hard in South Dakota. We have very dry, especially in the western side of the state. It's very dry. So that's something that I think is really helpfful for parents. Is baths are good as long as you can, as soon as they get out, grease them all up and lock that moisture in.
And do you find, on a separate note, in terms of if a parent says, "Oh, I'm concerned my child has a food allergy. I'm nervous about getting their regular scheduled vaccinations," is there any concern about that?
So there used to be in the past with the flu vaccine and specifically egg allergy, but now they've modified and changed how the influenza vaccine is created. And typically the only true kind of avoidance I recommend is if you've had a previous reaction from the flu vaccine, but not if you have an egg allergy itself. And the good thing is you can always schedule an appointment where it's in our office, where if you do have a reaction to it, then we can intervene.
Wonderful. So there's no reason to avoid your typical vaccination schedule or get any of these things in a way of being a properly vaccinated kid, which I'm sure we're all
There's very minimal egg protein in any of the vaccines now. With COVID vaccination, there's really no contraindication. Initially there was some concern about increased rate of allergic reactions to this vaccination, and maybe people who had multiple food allergies or other allergies should be concerned about getting it. We've really seen that it's the rate of allergic reactions is very similar to other vaccines. And my advice to people is, if you're someone who has a lot of allergies, take a lot of antihistamine for a couple of days before and after getting the COVID vaccine, for example. Most all of my patients, even those with history of anaphylaxis and chronic hives, have tolerated that vaccine very well. And so I think that's one myth that can be dispelled from my perspective, is having multiple allergies is not increasing your risk of having an allergic reaction to the COVID vaccination as well.
Wonderful. So you have this, this problem, and you want to be in American culture where we go out to eat and we have all this processed food. How do you advise families to eat out, or what advice do you give them?
So make sure if you have an EpiPen that you bring your EpiPen with you. It should be carried with you at all times. So we typically have one at home, one at school, just in case a reaction happens there. Let your waiter or waitress know so they can tell the kitchen that you have a serious reaction. Typically the menus have things marked on what proteins they could be in contact with. But the big thing is making sure you have your EpiPen with you and you know the signs of a reaction, so you know when to use it.
Yeah, I think parents of children with food allergy become strong advocates, and they have to, because I think for those of us who don't have children with food allergies or never had a food allergy ourselves, sometimes it doesn't even cross our mind.
Mm-hmm.
You go to a baseball game and you feed children snacks, and it's and grandparents, I think it's sometimes really hard for grandparents to wrap their head around this, because
Right.
food is love a lot of
Yeah.
times in our culture. And so I think that's a struggle for parents of food allergy, is needing to really defend their children and advocate for them. So label reading and just the parents kind of advocating for that, and teaching the child too that you have to live in this world where you're going to be exposed, and so you have to kind of advocate for yourself.
Do you give them recommendations for diet, for example, like don't buy processed food or avoiding processed food? Does that help reduce anything, or is it just the diet we encourage everyone to eat, which is a healthy diet with fresh fruits and vegetables? Or is there any other, recommendations for shopping at the grocery store?
So kind of doing always, the whole fresh foods, less processed foods, just in general, is the best for everyone. If we are going into those processed foods or things that are, in a factory, then being very mindful about label reading to see, are there going to be any cross reactions is important.
Wonderful. So in the last segment from Dr. Patel, she did mention sort of an unusual thing called FPIES. Would you be willing, Dr. Hushagen, to kind of elaborate on what that is, and how is that common or a concern that we should be worried about as parents?
So FPIES is a food protein-induced enterocolitis syndrome. It's a very rare and very severe reaction, and it's typically like profuse vomiting that ends up where you get a low blood pressure, as she said, lethargic, and oftentimes those are kids that need to go to the emergency room because they are just having such a severe reaction. They need intervention and IV fluid. So it's very, very uncommon to see.
And don't mean to change gears a little bit again, but so that's not terribly common, and we talked a little bit about home testing. We heard a little bit about allergy testing. When do you most, advise parents allergy testing is necessary?
Yeah, so I think as a specialist, I'm getting referrals a lot of times from pediatricians or family medicine doctors where they feel like, the history here is, a little confusing, or we're not sure, or, we don't have access to blood testing, or we don't want to, poke the child. And so if that's the story, referring to an allergist and doing skin testing is a very easy thing that we can do in the specialist office.
Wonderful. That's great advice. We'll be right back after this. Food intolerance and food allergy are common these days. When I was a kid, no one asked about nut allergies or gluten sensitivities when inviting you to a birthday party. You could bring homemade snacks to school. Peanuts were served to everyone on airplanes. Today, we are constantly reminded to be aware and take precautions to help prevent exposure for those who are intolerant or allergic. Understanding the difference between allergy and intolerance is important. Allergies can result in a life-threatening reaction, whereas food intolerances are not life-threatening, but can be very problematic. Food allergies and intolerance have many overlapping symptoms, making diagnosis difficult. Food intolerance is very common and is estimated to affect 20% of the world's population. Food intolerance occurs when the body has a chemical reaction to eating a particular food or drink. Most food intolerance reactions involve the digestive system, skin, and respiratory system. Many of us have mild intolerances, say to dairy, but other common triggers are gluten, caffeine, and eggs. Food allergies can be more serious and result from an inappropriate immune system response. Nuts, for example, are harmless, yet the immune system can identify them as toxic. Even a small exposure can lead to a life-threatening reaction known as anaphylaxis. Thankfully, we have new approaches to the management of food allergies. Today, we better understand how exposure to a broad variety of foods in infancy can reduce the risk of developing allergy as we age. Another option available is immune therapy for peanut allergy. On the other hand, managing food intolerance requires an understanding of what food or ingredient triggers the symptoms. Then we focus on avoidance. We do not have immune therapy for food intolerance. Both food intolerance and allergies are becoming more prevalent. For example, between 2007 and 2016, there was a 377% increase in the treatment and diagnosis of anaphylactic reactions to food. Why are people having more challenges with food? It is not clear. Maybe it is our environment, our diet, or both. No specific cause has been identified. Our world has changed, and our treatments for food allergies and food intolerance have changed as well. It seems we will continue to have special dietary requests for a long time to come, so getting the right diagnosis is our most important first step. Thank you to our guests, Halie and Kimberly, for volunteering their time to help us learn more about the difference between food allergy and food intolerance. As we continue to celebrate the 20th season, we invite you, our viewers, to tell us how this program has made a difference in your life. Please email or mail your story to the address on screen. If you would like to see and hear more episodes of this program, please like us and follow us on Facebook and YouTube, or visit us at prairiedoc.org. Look for the Prairie Doc perspectives in your local newspaper, and be sure to look for the podcast of this program, Prairie Doc On Call, whenever you get your podcasts. Thank you again for inviting us into your home as we celebrate our 20th season of truthful, tested, and timely medical information. For all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
Over the years, On Call with the Prairie Doc has investigated many subjects, unique cases, and everyday maladies. We've combined a few stories into Prairie Doc Insights. Next time, On Call with Prairie Doc, celebrating our 20th season.
Truthful, tested, and timely medical information for 20 seasons from the Prairie Doc. Hello, my name is Dave Heinck, and I serve on the board of the Healing Words Foundation, a 501c3 charity that secures funding for Prairie Doc programming. This year we celebrate 20 seasons of dedication, beginning with our founder, the late Dr. Rick Holm, and continuing today with our 4 Prairie Docs and all who volunteer their time to answer important health questions each week. Significant funding is required to produce and distribute our video, radio, and print programs throughout the region. Your financial support will help us continue the Prairie Doc legacy. On behalf of the Healing Words Foundation Board, I ask you to join us in our mission. Please go to prairiedoc.org and click on the Donate button today. Thank you.
Major funding for On Call with the Prairie Doc has been provided by Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, Ophthalmology Limited, South Dakota Academy of Family Physicians, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Vance Thompson Vision, Monument Health, Black Hills Medical Society, Brookings Madison Flandreau District Medical Society, Pierre District Medical Society, Yankton District Medical Society, Orthopedic Institute, Lake Poncet Sailing Academy, Aberdeen Asthma and Allergy, Dakota Bank, South Dakota American College of Physicians, and Swiftel Communications.